This is Chapter 28, The Child with Cerebral Dysfunction. This is the third lecture, the third portion. Other nursing considerations we're going to want to think about are cooling measures. We said sometimes with head trauma, brain trauma, children will run an extremely high temperature, so we've got to be careful of that and cool them down. Even if their temperature is not high, we might want to keep them cooler than normal, and that's to decrease the metabolic demands of the brain. If we can cool the body and the brain down a little bit, we might be able to minimize brain damage. Eyes. When we have a child in a coma, they're not blinking normally, so we want to be sure we're applying artificial tears to keep their eyes moist so that they don't have their cornea dry out and become damaged. Our goal is always to hope that they are going to come out of this coma, so we want everything to work as well as possible when they do come out. So range of motion. When you're not moving, you develop contractures, so we want to do range of motion to prevent contractures. Putting in a hand roll so that their hands can't stay tight can help, and something under their feet to prevent foot drop. And one thing that'll work on the feet is putting on high top tennis shoes, anything that keeps the foot in its normal position. And then making sure that we are still doing sensory stimulation. People who have been in comas say the last thing that they lost was a sense of hearing, and that was the first thing that came back. So we still want to talk to this child as if they're alert and understanding, and tell them before we're doing procedures, all those sorts of things that we normally do, we would still do. Now, causes for cerebral trauma: falls. Kids climb trees and climb stuff, jump over stuff. Motor vehicle accidents, bike injuries, all of these things boys engage in more than girls, so we see 2 to 1 boys having head traumas. If we're talking about an infant with head trauma, we really need to consider shaken infant syndrome. And here's what happens. You crash, you can see on the picture, it's the forehead into something. That's the coup, and this kind of shows you how the brain should be shaped inside the skull. There should be this nice distance between, and now it comes and crashes against the skull. When it does that, by shifting forward, we can tear vessels. And then after it's come forward and crashed, it kind of rebounds and bounces off and hits back here. All this back and forth movement, we have shearing down here. So we'll see that a little more as we go. So why are kids prone to head injuries? Well, they have that big head for their body, remember? And they don't have real strong muscle control of the neck, and especially the younger they are, the less control they have, and that's why we worry about that shaken baby syndrome. That's what puts them at risk. They also have a larger surface area, which means they have a greater chance of that intracranial bleeding from tearing vessels because of the larger area that the head covers. Okay, so what kind of injuries can we have? Well, compression, tearing, or shearing are all different types of injuries we can have. You get bruising at the point of impact, that's called the coup, and you also get bruising opposite of that. So the brain bounces against, if you fall forward, bounces against the front of the skull, but then rebounds off and bounces against the back as well, and that's the counter coup. So it's opposite of where the initial impact was. Our worst head traumas come from a sudden deceleration, so falling from a second-story window onto cement, onto something that doesn't move. So it's that sudden hit and stop. Well, the brain doesn't stop. It keeps moving till it hits the skull, and then it bounces off and hits the back. The shearing is mainly around the tentorium, that opening at the base of the skull where the main arteries and nerves all pass through. you push the brain back and forth across that, you get shearing down there. And when you have some sort of severe head trauma, you can have herniation. So the brain actually herniates down into that tentorial opening, tentorium. And here's another picture. We're tripping forward, hitting the forehead, and you can see the brain bounces forward where we have the coup and bounces back, the counter coup, and these vessels are what get torn, and down here, scraping along here, we get that shearing force. Okay, so what's a concussion versus a contusion? A concussion, you're going to have, it's something traumatic, and it's going to induce an alteration in mental status. This is our most common kind of head injury. It is transient and it's reversible. We don't see permanent brain damage, so that confusion passes and the brain ends up fine in the end. So what we're going to see is confusion, and usually there's amnesia of the event. People won't remember the exact time they, hit the tree or hit the whatever they hit into. That's a concussion. Now a contusion and lacerations are a little more significant. We're not just talking about bruising inside the brain, but some actual tearing of vessels. So the cerebral tissue has bruising and little, probably micro tears inside of it. This is what we see from the shaken baby syndrome. And we can also get lacerations when we have a penetrating wound, so something that goes through or breaks the skull and pushes a piece of the skull down into the brain tissues. So we get that laceration. Okay, let's talk about skull fractures. Because infants, their bones are not fully ossified yet, and they have those sutures that aren't fully closed yet, we see less skull fractures among kids than a little older, and so that's good. But when we do see skull fractures, we often see brain damage, but not necessarily. It really can range from no damage to the brain to very severe damage. We can get arteries torn or veins. When we get that depressed skull fracture, when a piece of the skull is broken and pushed down in, it's going to tear through that dura that's around the brain, and so we're going to have some leaking of CSF through that. You also, it's going to compress into brain tissue. Now with infants, sometimes we don't see, rather than a depressed fracture, it won't actually break a piece off, but it'll dent the skull. Think of it like a ping pong ball. When you push in on it, you dent it in. It doesn't break a piece off, but it dents it in. And so that can sometimes happen with an infant skull. Our most common and our most severe are these basilar skull fractures. This is anywhere, any of the bones along the base of the skull. So it's not a specific bone, but it means it's down closer to the neck, at the bottom of the skull. And these are some of the signs we see with that. Basilar skull fractures are the most serious ones, and as I said, it can be any of the bones, frontal, ethmoid, sphenoid, temporal, or occipital, and we'll see this battle sign because of bleeding under there, because we do tear vessels as we do this. You'll get this behind the ear, or the big black eyes, the raccoon eyes, and that's blood leaking from the sinuses into those specific areas. We can also, because we're likely to rip the dura, we're likely to get CSF leaking, and it can leak out the nose or the ears. If we've torn that dura, they probably are going to use prophylactic antibiotics because we don't want to get meningitis. We now have a very easy opening into the brain. And we also need to worry about the associated cranial nerves that could be injured. Now, if a child's had a head injury, we want to stabilize the child's spine before we move them or do anything. So we need a spinal cord injury ruled out before we are moving the head or moving them. So first thing is to stabilize that neck and that spine. And another nursing alert, we don't want to suction these kids if we can help it. Suctioning is going to raise intracranial pressure, which is just going to cause increased problems of increased intracranial pressure. So suctioning and NG tubes through the nose, through the nares, is contraindicated because of secondary infection, especially if we've made an opening into, through inside the meninges there, or if there's some fracture there, we could actually enter into brain tissue. So we're gonna, if we need to put something down, we're gonna go oral, but we're gonna avoid suctioning if we can, unless it's absolutely essential. Okay, bleeding out of the nose and ears is not very common, but if it does happen, it needs further evaluation. And if you get a watery kind of discharge, looks like rhinorrhea, just looks like a runny nose, we need to test that with a dextro stick. That's, the little dipstick, to see if there's glucose in it. If it's positive for glucose, this is not just nasal drainage, this is CSF fluid. So we're looking at a skull fracture and CSF fluid leaking out of the nose or the ears if it's positive for glucose. Complications: hemorrhage, obviously, that's kind of what we've been talking about. Infection, especially if we've torn the dura, we've got an easy access there into the brain. Edema, that cerebral edema, and herniation, tentorial herniation, the brain herniating down into the tentorium where it blocks off, the pressure will pinch off the arteries feeding the brain. So now you have a brain getting no oxygenated blood to it. This is what leads to brain death.